Welcome to this presentation on the principles of pain management in palliative care. We're going to be discussing the use of a novel opioid called methadone. When we evaluate a patient who has severe pain, we consider pharmacologic and non-pharmacologic therapies. An important pharmacologic option in palliative care are the opioids, and there are times when standard opioids are no longer effective or when patients have really challenging pain syndromes. And that requires us to consider very strong and potent agents like methadone. In the United States, we have quite a few different opioids available to us. Methadone is attractive for several reasons, and we'll get to that in just a moment. First, a little bit about the historical perspective of methadone. It was developed during the war when there were shortages of opioids because opium could not cross the battlefields and it was not reaching the hospitals where it was needed to treat our soldiers. And so the methadone was developed as a synthetic agent to meet that need. It was introduced into the United States in 1947 as dolophane, and although it was initially used for the treatment of pain, it quickly was taken up by addiction specialists who were using it as part of a methadone maintenance treatment program. More recently, we've begun to use methadone again for pain control, but there have been some very unsettling events that have been occurring. We're seeing the death rate associated with methadone increasing. Now, much of this is likely related to the illicit use of this drug, where individuals with substance use disorders are diverting the drugs from treatment programs or from patients who are receiving it for palliative care or other pain management issues. And they're using the drugs inappropriately. But there also appears to be death rates increasing in patients who are being given methadone for the treatment of pain. And one variable that has been identified is the use of concomitant sedating drugs. And this seems to place patients at increasing risk. Methadone is tricky because it has a very long half-life and it accumulates during some of the first days of treatment. And as a result, one needs to go very slow when escalating the dose. So a little bit about the pharmacodynamics of methadone. It is binding to the opioid receptors, and like all of the opioids that we use clinically, it's somewhat dirty. It binds to the mu receptor, delta. It also seems to bind as an NMDA antagonist. And this is important as NMDA receptor antagonist binding seems to be helpful in providing relief of neuropathic pain. It may also block the reuptake of norepinephrine and serotonin, much like some of our antidepressant agents. So when would we use methadone? Well, in one area, particularly in hospice, it's used often because it is very inexpensive. And in a capitated system where there's very little reimbursement, methadone is very attractive because of its cost. It may be used when patients cannot tolerate other opioids, true morphine allergies, for example, which are exceedingly rare. But where it's extraordinarily useful is when patients have neuropathic pain or when they simply cannot tolerate other opioids, or the pain just simply does not seem to respond to other opioids and they have uncontrolled pain. Methadone can be given through a variety of routes of administration, and that also makes it very attractive for the palliative care patient who may have difficulty swallowing. But it's available in tablets, in dispersible tablets, and in liquid. It can be given rectally as a suppository or a liquid, IV, sub-Q. There are some reports in the literature that it can cause some irritation locally, but others dispute the importance of that effect. Some have given it epidurally and intrathecally, but it's very clear that it's not particularly useful when given topically. Methadone is lipid soluble, so its absorption occurs primarily through the stomach, and it's metabolized through the liver, much like most of the analgesics that we use. Its elimination, though, is very unique. It's eliminated fecally, so there is some question whether methadone might be a very useful drug in people with renal disease. It has a very long half-life, which has been reported to vary from 12 hours to 190 hours. And there's large inter-individual variability in the kinetics of the drug, so one patient may respond quite differently from other patients. There was a Cochrane review that evaluated methadone's use in cancer pain, and initially it was reported to be effective. Another review by Eduardo Barrera's group at MD Anderson described its effectiveness, but that morphine is still likely the gold standard, at least when first selecting a first-line therapy. But here are some of the challenges in relationship to methadone use. It can prolong the QTC, and this can lead patients to arrhythmias. So we have to be careful when administering methadone to patients who have pre-existing QTC issues, or if they're taking other drugs that can prolong the QT. There are many, many drug-drug interactions, particularly related to the cytochrome P450 system and particularly related to the 3A4 enzyme. And as I mentioned, this long and variable half-life makes it quite challenging when escalating the dose and initializing this medication. So some of the drugs that will serve as inducers through that cytochrome P450 system will decrease the methadone effect. So if you have a patient on methadone and you add one of the drugs listed on this slide, they actually may report that their pain is increased. But these are the drugs, inhibitors, that are dangerous because they can increase methadone serum levels, thereby increasing the sedating effects of methadone, which can potentially lead to respiratory depression. And as you can see from these lists, many of these are drugs that we use often in palliative care. So the general recommendation is that we start low, 10 milligrams or less per day in divided doses in the patient who is opioid tolerant. If the patient is naive to opioids, you may even want to reconsider whether you'd like to start with methadone. And if you decide that it is the right drug, you would likely use an even lower dose, 5 milligrams, maybe just twice per day. And you do want to provide breakthrough medications for rescue, but not methadone. You'd want to use one of the other opioids. Some recommend that we increase the dose no more than 25 to 50%, and some suggest weekly, others suggest that 5 days may be safe. Be very cautious when using other drugs that can be sedating, such as the benzodiazepines, particularly at night, particularly in patients who are at risk. For example, those with sleep apnea or those who have respiratory infections. In fact, in an important paper published in Lancet Oncology, the authors concluded that methadone has a complex pharmacokinetic profile with an unpredictable long half-life. Therefore, it should be used only by experienced professionals. And at many institutions, the policy is that palliative care be consulted to assist whenever methadone is being used for pain management. Well, I hope this summary of methadone use in palliative care has been of benefit.